Welcome to BW Healthcare. On the occasion of the World Plastic Surgery Day, we have with us 4 eminent surgeons from Manipal Hospitals. I welcome Dr. Srikanth V, who's a consultant plastic reconstructive and cosmetic surgery at the Manipal Hospital at the Old Airport Road in Bangalore. We also have Dr. Anantheswar Y N, who's a consultant plastic reconstructive and cosmetic surgery, again from Manipal Hospital from the Old Airport Road in Bangalore. We are also joined with Dr. Sunil Kumar K S, who's a consultant plastic reconstructive and cosmetic surgery from Manipal Hospital, Whitefield. And we have Dr. Bharath S P, who is the consultant plastic reconstructive and cosmetic surgeon from Manipal Hospital, Sarjapur. I welcome all of you to BW Healthcare. Thank you so much for taking our time.
Thank you.
Thank you.
My first question is that which are the most common plastic surgery procedures in India? And you may choose, any one of you may choose to go in first.
Normally, plastic surgery means most of the times it is a beauty enhancement procedures as probably conceived by the common public. So the commonest plastic surgery procedures which we usually do, I'm coming to only the aesthetic aspect of it, that is also called as the cosmetic ones. So usually is the rhinoplasty, or what we call it as the nose job, and then the liposuction, followed by abdominoplasty or the tummy tuck. So these are the 3 commonest procedures, followed by breast either reduction or an enhancement procedures. So these are some of the commonest procedures which we do.
Anyone else who has a different view on this?
Yes. I would divide it into, we're talking about cosmetic surgery only. For men, I think it would come as gynecomastia, breast reconstruction, breast reduction of the male boobs, and hair transplant. So these are the 2 things which men commonly come in for. And women, like Dr. Anantheswar said, would prefer to get a liposuction or a tummy tuck done. What I have seen is that rhinoplasty is almost equal in both cases, both men and women with equal frequency or equally distressed with the shape of their nose. And tummy tucks are more common in women. That's what I've seen. Men will do better with liposuction. The incidence of men coming in for a tummy tuck is quite low.
What is it? You spoke about liposuction and tummy tuck. What is the difference between the 2? Who would want to answer this?
Liposuction is more where it's a minimal invasive surgery where you infiltrate saline in the areas where you want fat to be sucked. And you just make a small incisions in such a way that those scars are later on hidden and the fat is sucked. Whereas tummy tuck, it's just along with the liposuction, the excess skin is also removed. So this is tummy tuck, and liposuction is only removal of the fat.
Got it. Dr. Srikanth, I want to ask you that you spoke about hair transplant.
Correct.
Who are eligible for a hair transplant? Can anyone go in for a hair transplant? And what are the different methods of hair transplant that are available to us today?
See, the thing about hair transplant is, as the name suggests, it is a transplant. That means you're going to take it from one part of the body, put it somewhere else. So who is eligible is a person who has, 1, he should be losing hair. 2, he should have enough hair to give. That means we should be able to take hair from some part of the body. Usual place where we take from is between the ears. That is the strip of hair, which we call as the permanent area of the body, where the hair doesn't fall or it falls very late in, towards your 6th, 7th, 8th decade, so that most of your life through you will be having hair between the ears. So we take hair from here, put it in front, maybe in the center, maybe in the side, some people on the page, so that wherever you have a hair loss, you cover it. Who come in for it? We have a wide range of people. When hair loss starts early, we have people coming in at 20s, 22, 24. I generally avoid operating on them very early because such people are people who are candidates who might lose the entire hair. We do not know because there are very many factors, genetic factors, androgenic factors, which will affect the hair fall. And the right time probably is when the hair fall stabilizes between 25 to 35. You can get it done even after 35, 40. In fact, one of our oldest patients was around 68 years old who decided to come in for a hair transplant. But the common age group, I think, would be 25 to 35 is when they come in for a hair transplant.
Right.
If they have had one transplant, they can go for a second. And rarely there are instances where people have done what is known as a body hair transplant. That is, you take hair from the beard, some hairs from the body. But those are all only additional procedures. It is to be done only after you have done a scalp hair transplant. The results are good. They are happy. It lasts as long as you have hair on the back of the head. It will grow, it will gray. You can curl it, you can straighten it. You can do whatever you do with a normal hair.
So once you have a hair transplant, it grows normally?
Yes, it grows fully normally. The initial first 2 cycles of hair growth, that is, each cycle of hair growth 4 months. So for about 8 to 9 months, it will be slow, but the growth catches up, and after about a couple of years, it will grow as fast as your regular hair used to grow. So you will have to go in for a regular haircut, trim, shaping, all that will be normal. As you grow older, it will gray, and if you want, you can color it or you can let it be.
Okay. Dr. Anantheswar, how common is gynecomastia, if I pronounce it correctly? Is there an increase in the patients suffering from this, and what treatment options are available to them?
Essentially, gynecomastia means males having a little female disposition of the breast tissue. Normally, males have a flat chest, but when they have some sort of a very prominent breast tissue, they are called as, and also if it is associated with pain, so that is called gyneco. Gyneco means female, mastia means breast. That's all it means, basically. So they, to be very frank with you, the incidence is not increasing or anything like that. It must have been there even earlier days also. It's only a question of awareness. I feel that the internet especially has played up a more, and they have even some specific sites which are dedicated to this gynecomastia problems. So that is the reason the awareness has become more and more. I keep on telling that, look, when I was getting trained, not even 1 or 2 cases we did actually as a student, because the emphasis was not there at all about the gynecomastia, because it is not cancerous, it is not coming anyway in the way of your life or even reproduction problem. No problems will be there. It's essentially a question of social embarrassment. So most of these kids are usually around pubertal age, say in between 15 to let us say 20 years of age. Normally the puppy fat goes off around 15 to 18 years. In some it just stays back. So those in whom it stays back, then yes, it's a big problem. They are subjected to the peer pressure. They don't like to wear tight t-shirts. They don't like to go to the gymnasium, and they don't like to undress themselves in front of others, especially in swimming pools and other things. So more of a social embarrassment. They come to us only for that reason. So now, by your question, incidence, if it is increasing, no, it is not increasing the incidence. It is a question of probably the awareness has increased. So naturally, we are seeing more patients that way.
Dr. Bharath.
Yes.
We were talking of tummy tucking.
Yeah.
Now, tummy tucking is the common practice nowadays. What I understand is, and what are the prerequisites that doctors check in patients for this procedure? And what is the overall process? If you can explain the process of what tummy tucking is?
See, actually, Dr. Sunil has already given us a brief about the difference between liposuction and the tummy tuck. Tummy tuck, the most common subset of patients whom we choose for tummy tuck is post pregnancy and post completion of the family childbirth, where women will have little sagging of their abdominal wall in the lower part. So this skin, which is damaged because of stretch in pregnancy, doesn't contract back normally, and they don't regain that pre-pregnancy shape of their abdomen. And these are the ideal subset of patients who would look at undergoing the tummy tuck. And that way, choosing the right patients for this procedure is to select these kind of patients who are good candidates. The other subset, sometimes we get to see is patients who are very obese initially, and then they have undergone some kind of weight reduction surgeries, after which they have lost about 40-50 kgs of weight. And when their skin drastically, there is a sagging in the abdominal skin. And this is the second subset of patients in whom we have to look at a tummy tuck. And apart from these two indications or the subset of patients where we select the procedure, we'll also have to check into their general condition as well. Patients have to be fit enough for undergoing this procedure, and especially under the anesthesia. And they should not be, ideally not be smokers. They should not have any, comorbid diseases like severe diabetes or hypertension or even cardiac diseases. So they form a good subset of patients. And generally, if you look at the age bracket, about 30, 40 years is when all these women come for these kind of procedures, and they are fit enough to undergo the procedure most of the times. And when you look at the procedure per se, what we generally do is we make an incision which is very low well in the abdomen, so that later it is not even visible, and many even may not be able to make out that a procedure has been done. So we kind of take a transverse incision, and then we elevate the entire flap of the abdomen, which is completely lax. We entirely elevate it, and then whole laxity is kind of cut off. We just remove all that excess fat and skin from the lower abdomen, or also adjust right from the upper abdomen and even the sides, the flanks, and then completely tuck it down and stitch it in the lower abdominal part. So that briefly is the procedure, what is called as a tummy tuck.
Dr. Sunil Kumar, you spoke about liposuction and the difference between liposuction and tummy tuck. Now, can you in detail tell us what is liposuction and what happens? What do you do when you do a surgery of liposuction? And so if you can just explain that.
Nowadays, losing weight has become a trend now. So people think liposuction is an alternative for losing weight, and no, it is not true. The liposuction, it more favors the contouring of the body. See, whatever excess skin is there, provided you have a good quality of skin which can retract back after the liposuction, liposuction is a good procedure. Suppose if you mark certain areas and start doing liposuction, and once the fat is gone and if skin doesn't retract back, then the skin will sag more and becomes more awkward. So the ideal candidates for liposuction is the people who are in younger age group, who have a good quality of skin which can retract back. And if it has too much expanded, then better not to do only liposuction, and it has to be along with the excision of the skin.
So can you also explain who are the people you recommend should go in for a liposuction? And on the contrary, you can also explain who are the people you recommend should not consider liposuction? Who would not be a good case to be taken?
The patients who are morbidly obese and they think that you can get away with getting liposuction done, getting the fat out, they are not an ideal candidate for liposuction. See, whenever we do liposuction, around 5 to 6% of the total body weight is the liposuction amount which can be removed at one stage. Suppose if you weigh around 60 to 70 kgs, around 3 to 4 liters is the normal range of fat which you can remove at one stage. So usually we take pictures, preoperative pictures in erect posture. We discuss with the patients and tell what is the target and how much we can remove from the individual. And according to their priorities, we mark and show, and these are the areas which we can remove at one stage and which comes under the limit of one stage. And after that, we start infiltrating little saline along with adrenaline, which gives a good tumescent, which gives a good turgid medium for the cannulas to pass, and the fat is sucked. Once the fat is sucked and the ports are closed and the pressure garments are given. See, ideally, the patients who are of around the 70 to 80 kgs or 80, 90 kgs, they are okay. We can manage with liposuction. Anything morbid obese, they are not considered as a good candidates. And the candidates who have other comorbid conditions, like Dr. Bharath has already specified, like cardiac issues, known diabetic, known smokers, all these patients are not a good candidates for liposuction.
Once a liposuction is done, is it a permanent thing? I mean, does it remain permanent for every patient, or are there certain patients who revert, who come back to the old condition?
No. If they don't maintain their dietary habits, if they don't do exercises, if they don't keep themselves fit, there are high chances they can put weight back again. So it's not a permanent solution.
So what would be a typical life of a person And how does it change once the surgery is done? I mean, you or anyone else. I saw a hand coming from Dr. Srikanth.
Oh, no, I was just going to add to this thing of diet and exercise. There's a very interesting study which says that a person who is on a regular diet and an exercise has a 95% chance of being happy with the surgical result. Whereas a person who doesn't diet and exercise has a 75% chance of being unhappy with the result of the surgery. Whatever maybe however well the surgery is done by the same person, the same volume, the same center. This is a study which has come out of the US, and I think it's a very interesting study which focuses that if you don't diet, if you don't exercise, maybe liposuction is not the right procedure for you.
So does it mean, I mean, it's a very interesting that you mentioned, Dr. Srikanth, that does it mean that one should, as a surgeon, also dive into the lifestyle of the person before agreeing to do the surgery or recommending the surgery beyond the medical part of it?
Definitely. I would think that, I would tell everybody, give it a shot with diet, give it a shot with exercise. If you want, take on a personal trainer, because you're going to spend so much of money, you might as well try these things. A lot of them do well with this. And in spite of it, if you feel like, your belly is sagging a bit, or your buttocks are not going in, your thighs are too fat, come in for surgery, we'll help you out. But diet and exercise should be the first step for anybody who's aiming for either a good, a good body contour, or for losing weight, or for, a self-image kind of procedure.
Got it. I think this is very useful because this point usually gets missed.
Yes, yes, it does. It does. That's why this study is so important. Very, very pertinent kind of a study. It was done in the US, and I think it's very relevant.
As I stated earlier, people think liposuction is an alternative for losing weight. They just don't want to spend more time on the physical activity. They just want to get procedure done and okay, I'm done with it. So if you don't do exercises and maintain your diet, then definitely it will come back.
Right. So, Dr. Srikanth, let's move ahead. Let's talk about breast reduction. Now, breast reduction is another procedure which is common in plastic surgery across the world. Now, do you think India is coping up with this concept? And who do you think is the target patient group for this?
Yeah. See, breast reduction actually is quite a big problem in our society. In the past, people were not coming forward because one thing is it's a private part. And these are all teenage, young, adolescent girls who probably feel shy to tell their parents, that, I feel my breasts are too large, but they find the same amount of, discomfort in social life. They're being targets of ridicule at school, college, hostel, and they become reclusive. They don't talk about it. Nowadays, because of awareness, because of, as Dr. Anantheswar mentioned, internet and all other sources of information, social media, they come forward, they talk about it. And, when you really talk to them, you realize that, they have a tremendous body image issue. They suffer from neck pain, back pain, and very severe ones get, this bra strap shapping, they get intertrigo between the breasts. These people benefit with surgery, and they are some of the most grateful patients I have ever had. This is because it's only the patient who knows the burden of the problem. We can only imagine it. And what we need to do is to address the problem, reduce the size of the breast, and they get on with their lives completely. They are so happy. And also nowadays with the kind of lifestyle that we have, that is, too much of fast foods, childhood obesity, then lack of exercise with, too much of screen time, whether it's games or TV, they tend to put on weight. And when they try to lose weight, the breast may not reduce or it looks too big for them. So these are the people who come in for breast reduction surgery, and they do extremely well. There is also another subset, post-pregnancy, post-lactation, the breast doesn't involute fully. So if this happens, then the female, it goes through a sort of trauma that, the breasts are sagging, they stay below the level of the elbow, the nipple stays below the level of the elbow. These are the people who come in for breast reduction, and they are extremely happy. They're extremely grateful with the procedures that we have done. And nowadays there are a lot of techniques, to hide the scar, minimize the scar, and to preserve the sensation on the breast. Previous techniques, there were some of issues with the nipple areola sensation. Now we're able to preserve this nipple areola sensation, including erotic sensation. So these are the newer techniques that we have, which we can use on these patients, and they're very, very grateful.
So I believe I'm made to believe that there are a lot of fear in the minds of a patient in terms of they don't know what happens when the surgery is done. So can you explain in brief as to what entails this surgery, what actually happens, and what is the post-operative care that they need to take care of?
Yeah. See, breast reduction surgery is basically a full-fledged surgery under general anesthesia. So what is done is first we work them up for all the medical problems, like they check the function of the heart, the kidney, the lungs, the hemoglobin levels, the blood sugar. Once these are normalized, then we know the patient is safe for surgery under general anesthesia. On the day of the surgery, they are admitted for surgery. They are taken to a marking room. In the marking room, careful measurements are done, something like tailoring. So we take the length, the breadth, the height, use a measuring tape, we mark, we check in front of a mirror, then again mark. Then once we are satisfied, this whole marking process takes about half an hour to 40 minutes for a patient with a breast reduction. Once this is done, then the patient, we also consult them, this is what the size that you would be getting into. Surgery is done under general anesthesia. Depending on the speed of the surgeon, it may last anywhere between 2 hours to 4 hours. I would like to think that, I'm a medical surgeon, so I will take time. Post-surgery, there will be small tubes called as drains, which are kept. These drains are there for about 24 to 48 hours. The wound healing period is about 10 to 15 days. And in about 3 weeks' time, they can get back to all their activities, running, swimming, cycling, jogging, everything. And in about 3 months' time, they can fully appreciate the breasts that they had opted for. It takes about 3 months for the tissue swelling and the scars, everything to settle down. We have many techniques, like I said, to hide the scars, to minimize the scars. And in about a couple of years' time, they won't even notice that they have had a surgery done.
Dr. Anantheswar, my question to you is around the rise of facelift and eye lift procedures that are done by famous personalities, celebrities, etc. How far do you think is our society's acceptability on this procedure? Is this procedure a long-lasting procedure?
Well, to address your first question, yes. Fortunately, our Indian subcontinent population is endowed with a very good quality skin. Our skin, if you compare, it is a bit oily and a bit thickish. So that is the reason we do not get into the stage of wrinkling compared to our Western counterparts. If you see anybody from abroad, so they start looking better around 20, 25 years. And at the age of around 30, 32 years, it starts wrinkling. So the early wrinkling will start in them. And by about 40 years, they definitely require some sort of these procedures like blepharoplasty, what we call the eye lift, or the eyelid lift, in which the eyelids are raised up into it by inconspicuous scar margins. And facelift is in which the sagging face is brought back into the normal shape. Now, surgical rejuvenation is about approximately, it is not like, showing the face in the mirror and saying that, look here, I'm going to do it like this and you will look like this. It never happens like this. As the age advances, there are certain biometric lines which happen in our face. If you see the forehead wrinkles, or if you see the smile lines, so these are the natural crease lines which will happen in our body. So by doing a facelift, what happens is basically these are addressed to such an extent that they all look, you have a pleasant rested sleep night, so that your face looks fresh. So I would say that you will put back the biological clock by these surgeries by about 10 years. Let us say if you get the surgery done at around 50 years, you will start looking, you won't look like 20 years, but definitely you will look like around 40. So that is how it is the thing. And of course, the scars are all very well hidden into this because it goes virtually into the hairline, and then it goes into the just in front of the ear and then back into the behind the ear. So most of these times, the scar is virtually hidden away. And regarding the eye lift, or what we call it as the eyelid lift, as the age advances, the upper eyelid skin starts sagging down. And in some of the cases, even the lower eyelids are also baggy skin appearance will happen, giving an appearance like a froggy eyes. So in order to counter all these things, a procedure called blepharoplasty is done, in which the excess eyelid as well as the fat underneath is carefully removed. And the existing scar lines will look as if it is a part of the natural skin lines. So if you ask me, is there a scar? Yes, there is a scar, but the scar is so well hidden that in a natural skin line, so that virtually you can't make out that yes, they have undergone a surgery. Now you are asking about the longevity of these procedures. Yes, once you do these procedures, definitely they are very, very long lasting. So first of all, the incidence of facelift compared to Western countries is little less, because we, as I told you, our skin quality is much more superior because of the oily nature. So we don't do that much on Indian patients. But to those who come from the abroad patients, yes, they do about at least 10 to 15 years of life is there for these surgeries before we contact into doing or planning for the next surgeries. Yeah.
So, what are there different procedures or minimally invasive surgeries? Are there treatment options that are available?
Yeah, there are broadly it can be classified as some sort of a non-invasive or invasive. Invasive means, which I just talked to you about, the facelift and the brow lift and the eye lift. These are some of the standard procedures. Now the minimally invasive is in which you feel that the skin is sagging, but not to that extent, wherein you probably adopt a little bit of lighter methods. So one is called as the laser rejuvenation, in which you do the whole face rejuvenation by a careful laser typing, so that the body it's a burn, but it contracts and then it starts lifting up the skin back into the position. That's number one. Number two is the minimum thread lift, what we call it as, carefully supplied threads along the creases and then subcutaneously passed, means just below the skin, and anchored onto a better space at a higher level. So the whole skin gets lifted up like that. That is also a semi-invasive, but a smaller procedure. And of course, the dermatologists, they are very fond of doing these chemical peels. You have these full face peels, which is akin to a laser. It's a tool is different, in which they use a little bit of burning, sort of a very mild acid, so that the skin gets evenly toned up and then it heals up in a heightened fashion. Yeah, that is what it is.
I have this question. When you were explaining that the minimally invasive, where you have this thread which goes and anchors itself to some stronger part. Yeah. Now, after this kind of a surgery, does the person continuously, will the person be feeling it internally?
They won't feel it internally, but as it cannot be compared to a conventional facelift. Surgical facelift is always the choice of the procedure, because definitely if you imagine that these are the 4 threads I have put, something like this. So these 4 threads, after some time, suppose the skin starts tenting in between the thing, it can look, whereas it can never happen in a facelift procedure. Facelift is much more uniform and much more, of course, it's an elaborate procedure. Yes.
Got it. Let me come to you, Dr. Bharath.
Yes.
Is rhinoplasty a common request among both genders? And if you can explain, how is it done?
Okay. Yeah, see, rhinoplasty, I think Dr. Srikanth has already mentioned earlier that these days we do see that both genders, come in equal numbers. They do have requests for change in the shape of their nose. Rhinoplasty basically involves changing the shape of the nose. And see, broadly speaking, in any plastic surgical or in any cosmetic surgical thing, we need to look at 2 different things. One is the form. Form, when I talk of form, it's all about the cosmesis. It's about the aesthetic thing. The other important part is the function. Is there any difficulty in the function? So when you talk of rhinoplasty, the form is nothing but the shape of the nose. And the most common indication, the reason why patients come to us is because some are not happy with their, the shape of the nose. Some can be a very bulky nose, a bigger nose, or some can be a shorter, or a saddling, what we call, which is the dorsum of the nose, which collapses, either because of some accident or trauma or whatever previously. And this is one common indication. The other common indication when I talk of function is that some patients might have difficulty in breathing. because of the deviation in their septum. Septum is nothing but the partition between the two sides of the nose, the nostrils, and then there is a midline partition. So that partition, most of them, it may not be straight. In some of them, it is more deviated so that one side they feel difficulty in breathing. So these are the two broad indications why patients come. And these days we do see both men and women asking for the change in the shape of their nose. Though probably the cosmetic indications or the cosmetic reason for asking for a rhinoplasty change surgery is more in women, but both do come for the surgeries. And when you look at the procedure per se, see, rhinoplasty is slightly complex surgery, and definitely the patients have to choose a very well qualified surgeon, especially the plastic surgeons and the experienced ones to deal with it. Why I say this is because nose is a three-dimensional organ when you look at it. It's entirely three-dimensional and it has got multiple layers into it. So broadly, we can consider the outside skin. Then there are two bones on top of the nose towards in between the eyes. And then when you come down, there are cartilages, the softer ones below. That is the tip of the nose and in the middle part of the nose. And when you go inside, there is also a partition. So all these together form the nose. So basically, when you try to do a surgery, we are addressing all these four components in one way or the other, depending on what deformity or the defect the patient has. So basically, when you choose a patient, you need to talk to the patient multiple times. You need to examine the patient multiple times to make sure what exactly he desires. Whether is it a cosmetic part which is bothering him or whether it's a functional part which is affecting him. And based on this, you'll have to kind of design a plan for the surgery. And broadly speaking, if we talk of the rhinoplasty surgery per se, it's again, you'll have to do it under general anesthesia. And in collapsed noses, what we try to do is the dorsum, we try to lift the dorsum by either using an external cartilage, additional cartilage piece, so that it gives that shape. And then the septum, the most important is the septal part, it has to be straightened, which is called a septoplasty, so that both the airways are equal. And then the patient, post-surgery feels much comfortable with his breathing terms. And when you come to the tip of the nose, again, some patients have a very bulbous, very broad kind of nose, and that involves a lot of cartilage work inside. You'll have to make incision below the nose. Again, that incision is in hidden area, which is not even seen, and some part of the incisions get into your nostrils. So there you'll have to open that out, and then the cartilages are all reshaped and redraped and lifted up and held up so that it is made more narrower and more pleasing.
I understand that, when somebody has a problem and they're coming for the medical reasons to correct that.
Correct.
But the people who come for cosmetic reasons because they do not like the shape of their nose, are there any risks that they need to be aware of?
Sir, that's what, when we choose the patient, we have to be extremely careful in choosing our patient, especially for cosmetic surgeries, for any cosmetic surgery, not just rhinoplasty. That is when, repeated counseling of the patient, repeated talking to the patient, looking at what their actual goals are, why they are getting it done. The motive for the surgery also is very important. Many times the patient herself has to be motivated enough and then convinced enough that she needs the surgery. Whereas in our setting, what happens is many times it could be because of pressure, external pressure, somebody from the home or a peer pressure who keeps telling them that you get this done, get that done. Probably those kind of patients are not a good patient to operate on, because they'll ultimately end up being unhappy, what we kind of try to do there.
What is the sorry, please carry on.
Yeah. Tell me, sir.
No, please carry on. You were saying something.
Yeah, so choosing the patient for cosmetic surgeries becomes very, very, very important, very central. So we do about 2 or 3 consultations separately. Every time we ask them to make a list of what problems they have to list it out according to the order of priority. And then, at each session, we discuss with them, we take their photographs, we project their photographs, tell them what can be done in terms of surgery. And it's good that patient should have some kind of a realistic, sometimes we get patients who carry pictures of all these celebrities. And they ask us to, make a nose like Aishwarya Rai's or whatever. This really happens. They come with a picture of a celebrity and then ask us to do that, which is very unrealistic goal, basically, because each nose is different. When you look at each nose, each individual's nose is different. And then we'll have to work it around that nose and make an individualistic kind of a plan for the surgery.
And usually the patients who come to you for a cosmetic surgery, they are of what age group? And is there a recommended age for the surgery, or if there a minimum age that you say that below this I will not do surgery, or if somebody is older than this I will not do a surgery?
See, the commonest age group is definitely the young patients. The young people, around 20s, 30s are the most common subset of patients who come for the rhinoplasty. They are the ones who seek for the rhinoplasty. And if you ask for a minimum age, yes, definitely more than 18 years in our Indian age, who are, good, mature enough to understand what they have to undergo. It's not just that somebody brings the patient and asks us to do this procedure on them. No. Most important is to make the patient understand that what we are going to do, what we are going to offer, what is the entire procedure, and what to expect post-surgery, and what is the recovery and things like that. So obviously, anybody above 18 years and mature enough to understand would be the ideal patient for us to choose.
So would you do a surgery on someone who may be an asthma patient?
Actually, if you look at contraindications or in whom not to do, definitely the patients who have got other comorbid conditions like severe asthmatic conditions or severe lung diseases, cardiac conditions. We call it as a relative contraindication in our terms. Basically, you'll have to choose, even if somebody insists for a procedure in them, we have to kind of prepare them for the surgery. Pre-surgical, we get their lungs better, we get their hypertension or whatever cardiac condition under control. If it is a uncontrolled sugars, you can always bring it down, control it with medications, and then take up the patient for surgery only when they are fit enough. If you ask me, is there any higher upper limit for age group? Ideally, there is no upper age limit. You can do it in any age group, provided they are fit enough to undergo these procedures.
I just wanted to add to his, the lower limit of the age. We are all taught that 18 years is the minimum age you should go. But I feel that, Indians are a little slow in growing up. Our facial structure, our bony structure, we are not like the Westerners. Like Dr. Anantheswar mentioned, our growth, the way we mature is slightly different. I think that you should, see how the person has matured. Does he look like a full adult? Or if he's still looking youthful, then maybe to hold on the nose job, because, the growth centers are not fully developed. He's still got a potential to grow, to change. So anywhere 18 plus or 21 plus probably would be a better age to do a nose job.
Right. That's right. Yes.
So, Dr. Sunil Kumar, let me come to you. I want to understand what is body contouring, and what does the procedure entail? And one of the biggest fear is that if I were to go in for a body contouring, there will be scars, and especially women are very cautious about this because our traditional Indian attire is saris, and would the scars be visible?
See, body contouring is a procedure where the different parts of the body from head to toe are addressed. Usually these parts are very commonly observed when you go for a functions or when you go for a parties or anything like that. See, body contouring starts from head to toe. See, initially we can start with facelifts. You can do blepharoplasty like Dr. Anantheswar mentioned earlier, and anything like pertaining to the chin, you can address double chin. And coming to the abdomen, so whatever fat accumulated in the abdomen, waist, and it's also commonly called as truncal obesity, that is also addressed. And anything pertaining to the lower limb, that is in the thighs, the medial parts of the thighs, whatever fat depositions are there, that is also addressed. See, there are two types of people who come, both men and women, they both come for body contouring. Coming to the with women, for example, post-delivery or post-pregnancy, there are a lot of physiological changes which happen in the body. So because of that, there are changes in the body which happens in the breast, happens in the arms, happens in the low back, and in the waist and in the thighs. So coming to these problems, we start doing from head to toe. See, starting from the top, We can address them for the breast changes which happen. See, some patients, they undergo post-lactation atrophy, and some patients undergo hypertrophy. The patients who undergo hypertrophy, that is, there's an increase in the size of the breast. So like Dr. Srikanth earlier told, there's a lot of problems happening because of the hypertrophy of the breast. The post-lactation, the size may reduce, but the sagging stays. So there's a lot of infections happening, intertrigo, and a lot of upper backache because of the increase in the size of the breast. So we address that. So we do reduction mammoplasty for the patients where there is hypertrophy of the breast. And there are some patients who are in a younger age group, but still they have conceived, they have delivered, and the breasts are not looking good. So they undergo augmentation mammoplasty. See, this is regarding the breast changes which happen in the women. And coming to the arms, there is a lot of sagging, there's a lot of fat deposition which happens. That can happen due to the hormonal imbalances also during the pregnancy. So once they are off the delivery and all those things, whatever changes which was already happened may not come back to the normal stage. So all this sagging which is happening in the arms also are addressed by, initially we do a liposuction and see, and if the skin is pinchable, we do skin excision also in the medial aspect of the arm to avoid the scars to be seen outside. And coming to the abdomen, like Dr. Bharath had already mentioned regarding this, the tummy tuck, normally commonly used term. So what we do is we do suck out the fat and in the lower abdomen and in the flanks, and whatever excess skin is there, it is excised and tucked it in a tight manner, which gives a good contour. And coming to the medial aspect of the thighs, there is a lot of fat deposition which happens there also. So we can, if it is a minimal fat deposition where we can get away with liposuction, we make incisions in the creases where it can be hid easily after the procedure, do the liposuction and give a good pressure garment. If the skin quality is good, it will contract back. If the skin quality is not good and if you have removed the fat, then that excess skin is excised. Again, as we did in the medial aspect of the arm, we do it in the medial aspect of the thigh so that the scars are hidden. So this is coming to the women who undergo this. Coming to the male, there are people who have lost weight because of post-bariatric or because of massive weight loss and all. Even those patients undergo body contouring where double chin is addressed, their chest, their abdomen, and the same, even the thighs are addressed. This is body contouring.
My next question is open to all. What are the common myths that people have, which you as experts would want to bust today, related to plastic surgery? So whoever wants to answer this question.
I think I will start with, because there are many misconceptions. So I think even if we address one, I think we'll be able to address quite a bit of myths and facts about plastic surgery. First of all, our discipline was earlier called as destructive surgery. So that means to give structure. So around 1870, there was a person called John Dassault. He told that no, better name is plasticose. Plasticose means exactly to shape, to mold. So we started becoming known as plastic surgeons. So then the story happened, everything was fine till about 1920, when the first commercial, you can say the synthetic plastic, or what we call it as the bakelite, was manufactured. Then all hell broke loose. Then people started thinking that, okay, plastics means plastic surgeons, they will put plastics into it. So there is nothing like plastic about it. We do use some of the synthetic materials like, proline or silicone, implants, various other things. But definitely not the way people think that the commercial plastics are being put into the human body. No, that's a big no about it. So this is one about it. Then the other one which I would like to touch upon is people think that, plastic surgeons means they can do scarless surgery. That means absolutely without putting any incision, you can do a surgery, which is humanly impossible. I feel that somewhere you have to address a surgical problem, you have to cut somewhere. And when you cut somewhere, the logical outcome is a scar. The operative wound also heals by scar. The injury wound also heals by scar. So scar is a very logical outcome. What the emphasis has to be is that, from a scarless surgery, the plastic surgeon can give a better scar, more hidden. So it is a less scar surgery, not scarless, but less scar surgery. These are the two things which I would like to tell. The third one onwards, my other fellow colleagues will elaborate upon.
Yeah, the other commonest, day in, day out, what we hear is plastic surgery is only about cosmetic surgery. Everybody thinks that, oh, you're a plastic surgeon, you can change my face. So, which entirely is not true. So, cosmetic surgery is just one part of the plastic surgery. Plastic surgery is quite a broad specialty. Like I told you, we have on one hand cosmetic surgery, the other hand, there is an entire gamut of reconstructive surgery. When I mean to say reconstruction, we kind of try to repair or replace any part of the body which is damaged, right from head to toe. So we as a specialty, we don't have one particular organ or region named for us. We kind of intervene in any portion where we have lost a body part or damaged body part, something like say because of an accident, some part of the body is lost. So we need to reconstruct that. Or because of cancer, the cancer surgeons kind of take out one portion of the cancer involved thing and we try to reconstruct. So under reconstructive surgery, we do a huge gamut of, like post-trauma reconstruction, post-cancer reconstructions. Now the hand surgery, the entire hand surgery itself forms a separate specialty for us, wherein we deal with all the structures in the hand. We reconstruct all the structures. Then even congenital anomalies, babies born with any congenital defects. For most commonly the cleft lips and the palates which are broken. Sometimes the fingers are fused. They are called as syndactyles and polydactyles, commonest ones. So any congenital birth defect, people are born with absent ear lock, complete absent ear, which we reconstruct. So plastic surgery is not just cosmetic surgery, but it also it involves entire range of both cosmetic and reconstructive surgeries. That is one common myth which is there amongst everybody. Surprisingly, even amongst the medical fraternity, the other specialties, they don't realize that we do this entire range of procedures.
One more thing, like Dr. Anantheswar sir mentioned, it's scarless surgery, they say. See, any traumas we come across, we would have done good debridement, we would have used good layer closure, and we would have used fine sutures and all. But instead of doing everything, they will end up having some amount of scar. Then patient will come and ask, when are you doing plastic surgery, sir? So they don't understand that whatever we have done is not a plastic surgery. For them, plastic surgery means beautification. They should not have scar. And one more thing, what they think is plastic surgery means taking skin and putting. Sir, when are you putting skin, sir? When are you doing plastic surgery? This is common questions we come across when we treat trauma patients.
The other thing is the myth that people have is plastic surgery is for the rich and famous and the who's who of society. Well, I would like to say no, it is not that so. A bad nose, sagging breasts, sagging abdomen, troubles across the spectrum of society. The rich are troubled by it, the middle class are troubled by it, the low middle class are troubled by it, the poor are troubled by it. The only difference was the access and the affordability. Here at Manipal, we have tried to position ourselves to our local population, that is the kind of people who come to us. We try to make it affordable for them. And everybody can benefit with this kind of skill. So it is not that plastic surgery is meant only for the rich, the famous, or the movie stars and the TV stars and the people in the, living in the limelight. It is meant for all. Anybody can have access to it. If you have a problem, meet your plastic surgeon.
Got it. I think these are very, very useful myths that you have busted because, I was looking at my nose when I was listening to all of you. I was getting cautious. So, Dr. Srikanth, my next question is to you. We've spoken about liposuction, we've spoken about tummy tuck, we've spoken about rhinoplasty. What is lymphedema? And what are the lymphedema? What are the different treatment modalities that are available for this? And is there a role of technology that has transformed the way the surgery happens?
Yeah, all pertinent questions. Let me start with the first one. Lymphedema basically is a condition where there is fluid accumulation in the hands, legs. Commonly, it can happen any other part of the body also, like the genitalia. What happens is there's a protein-rich fluid which does not come out from the artery and the veins. It gets stuck in the skin and slowly it swells up. Till the recent past, we had only destructive surgeries to treat these kind of procedures. In the sense, whatever is damaged, you remove it. The commonest problem was filariasis or elephantiasis, which we see along the coastlines because of the kind of mosquitoes which harbor these organisms that are there. There are also other reasons because of cancer, because of lymph node dissection, because of radiation, people get lymphedema. So typically what happens is the leg or the hand over a period of years swells up and swells up and swells up. Then they get repeated infections. Sometimes they can be life-threatening infections. And then they form wounds and ulcers, and then it starts weeping and oozing fluid and things like that. When it gets infected, it smells, they become social outcasts, they become reclusive, they don't go to social function, they don't go to work, and they become a burden on the family. So this is lymphedema, and in the past, these people were only offered an amputation to take care of it. What has happened nowadays with progress in science and technology, our optics and microscopes and our technology, we are able to address this problem. Our understanding of lymphedema has improved miles and bounds. We know the problem, we have a solution for it. In fact, what we do is we do something called as an ICG scan. Indocyanine green is injected, it is a dye, it glows in infrared, and we use a handheld infrared scanner, and to scan, we can see real time. We can see what is it, where the lymphatic is going, where it stops, where it is blocked, is it spreading out, and depending on these, we can afford surgical solutions. The other technological advancement is the microscopes. All of us plastic surgeons are trained to use microscopes. We are comfortable using operating microscopes. This lymphedema surgery is called a super microsurgery because it is even more fine, even more smaller. Instruments are even more delicate. The sutures are so much more finer. But we are able to do this because we are able to attach a lymphatic to a vein. We are able to take lymphatic from inside the abdomen and put it out. And these people are extremely happy. So these are the exciting times for lymphedema surgery. And I think previously people used to be hesitant to treat them. Today we can come forward and say, no, you come to us, we will treat you. We have excellent solutions. Technology is there to back you. And one of the interesting things in technology nowadays is a high frequency ultrasound. These ultrasounds are so beautiful, so beautiful. You put it on your hand, you will be able to see those lymphatics. It is amazing if you see it. That you're so surprised that, there are so many other structures so small inside the body. We're able to see it, we're able to tackle it, see it real time, and use them to anastomose do a lymphovenous anastomosis. So technology is there. We have excellent backing with technology with all these instrument makers and companies, and we have the facilities in our hospital. So anybody with lymphedema, I think, shouldn't give up hope. They don't consider themselves a burden on the family. Rather, they should come forward, and like any other disease, the earlier you come, the better your results. The later you'll end up in the hospital, that much more complications are there. Technology is one place where we have seen technology change, well, since the time where we were training and to what we are practicing now. Technology has just made a complete U-turn towards lymphedema. Everybody who used to run away from lymphedema now wants to say that, yes, no, we have the ability to treat it. Yes, we can do it.
Right. You know what? It's really beautiful because what I understand is that there was actually no treatment option available many years ago. Amputation is not a treatment. It's basically
just a solution to a problem, but not the ideal one. And in fact, we used to also offer them in our training days. If the leg is very infected, bad, life-threatening, we say, yes, amputation, you do it. But today, we tell them, no, we will preserve your leg, we'll keep your leg, we will be able to do this. Just give us some time, maybe 4 or 6 months of your time, and yes, your life is much, much, much better.
Got it. Dr. Anantheswar, what are the bases of craniofacial surgery? I mean, what are the recent advancements that have happened in this field?
Oh, yeah. See, craniofacial surgery essentially means the surgery which is involving the face, the base of the skull bones, and of course the facial bones. So essentially these are the structures as a separate one. It comes together and it can be afflicted in various conditions. Like for example, in about 1 in 2,000 births, some of the children, they will have an early fusion of the skull bones. Normally the skull bones are not fused in a baby. about 1 to 1.5 years later, it will start fusing together. So it is essentially God's idea that, if the brain is given enough time for its development, up to about 2 years. If they fuse early, the brain doesn't have space to expand. And so it can produce tremendous pressure on the brain. So with the fusion, also there is a compensatory deformation which can happen in the other side of the skull. So which we call it as the craniofacial deformities. So this is from the birth defect. Earlier, yes, people used to think that, these are not operable, these are very dangerous zones, nobody can do anything touch about it. But nowadays, as Dr. Srikanth was mentioning about the technical advances, these technical advances have made their way into this field also. Now we have moved into various, cutting instruments. Like earlier, we used to use only a saw and a chisel virtually, like any stone crusher. From that onwards, we have moved into various type of new pneumatic drills, electric drills, and then nowadays you've got a very fine piezoelectric drills. So which you can do a nice, sort of a bench surgery in which you can take out the entire skull, reshape it the way you want it, and then put back into the baby's skull, which was virtually unheard actually when you are thinking about doing all these surgeries earlier. So that way, it is a real technological leap, I will say that, whenever you are talking about craniofacial surgery. The same way, you also have something called as the titanium plates, which are more expensive than gold, platinum, and then titanium comes like that. So they integrate so well with the bone that, you don't have to virtually remove it or anything like that. Unlike other earlier implants like stainless steel, which used to have problems because of their metallosis and rusting. Second thing is, now even we have moved away, and then in a child, you can even have something called as a resorbable plates. That means you put the plate and screw, it stays for about 6 months, and then it just merges and then dissolves automatically, like any dissolving stitches. So they are now available. The same way, if you see, the many indications are there for a craniofacial surgery. One, I just talked to you about this child, which are usually inflicted with a birth defect, or what we call it as the craniofacial syndromes. The second one is the commonest one, is what we come across commonly across all age group as an accident. If you see the people meet with an accident, of course, now kind courtesy Nitin Gadkari, we have got 8 lanes and 10 lanes roads. So definitely it is much better. So, but we have facial injuries which happen quite a lot just by not wearing a helmet or not following a road traffic signals. And we have a lot of facial fractures which can happen. So these are again tackled by us in a very systematic way and a very sophisticated way. And also there are certain areas, what we call it as the no man's land, in which there is an entrance of the brain, or what we call it as the base of the brain. There are some individuals who have been afflicted with some tumors at the base of the brain. So earlier it was thought that because nobody can reach that place, so there was no treatment. Surgically, it was just not, options were not available, as you were mentioning for the lymphedema cases. Nowadays, you can just open the window like that, like a skull. You can open the window, reach that spot, use a gamma knife or anything like that to read the tumor excision, put back all the bones back into the position, and then you can come out with the thing. So virtually, the technological advances, especially in the field of craniofacial, is fantastic. It was virtually unthought of, unheard of, but now I think it is, as a matter of fact, many centers, especially in our center, we definitely do a lot of craniofacial surgery. So one of my favorite topic also is that. So it's a very satisfying thing, and children are very happy about it.
But what while it is simple and technology has made it simpler, what are some of the challenges that you have encountered while doing craniofacial surgeries?
Well, craniofacial surgery is more of a systematic physical analysis, basically. It's more of a technically driven and technically oriented surgical discipline. The rest, everything is much more mathematical. Actually, what we are doing is, suppose there is less space, you have to create more space. And if there is more space, you have to reduce it. So like that, it is like an algorithm, it moves on. So definitely what has changed is what I just mentioned to you about is the newer instrumentation panels, and then the newer suture materials. Everything has really added upon to the thing. And also the awareness. Yes, again, same story. Again, coming back to that same awareness, people earlier thought that, oh, okay, deformational deformities of the skull, The parents used to think that, no, this is a curse from the God. We can't help it. We have to allow the child to leave it. Actually, otherwise, it is a normal child. If he was just given a chance to operate early, within just, let us say, 6 months to 1 year, it would have grown into a normal adult. There is absolutely no problem with the brain. Just because no awareness, no surgery, no place for the brain to develop, and unfortunate incidents. So this is how it looks.
So I think a lot needs to be done in the field of awareness or creating awareness for these surgeries to break the myths that we as a society are dabbling with. Dr. Bharath, let me come to you. How do plastic surgeons contribute in head and neck cancer surgery procedures? And what are the outcomes after the plastic surgery procedures in these specific cases?
Actually, if you look at the head and neck region, head and neck, like previous speakers have said, it's a very complex region. You have a lot of structures packed into your, the face, the skull, the brain, and things like that. So previously, a few decades ago, head and neck surgeries, used to be very mutilating to the patient. If there is a cancer-afflicted part, say for the jaw or even the maxilla, they used to do a complete extirpation, complete removal of that region. And there were very few options for us to kind of cover those areas. And obviously, the cosmesis or the aesthetic part, the presentability of the face was not in earlier days. So that used to be kind of a limiting factor for the oncosurgeons, because it's going to be mutilating. Probably even the patients who may not approach the surgeons in the right time to get it removed, because it's going to be mutilating later. Or even the oncosurgeons would feel that, I will have to remove so much more, for the curability and things like that. So he might limit himself on that aspect. But like Dr. Srikanth and Anantheswar mentioned, there has been huge technological advances in this field also. So now these days, what happens is, because we as plastic surgeons are able to replace like tissues with like, what we say, for example, if skin is gone, we are able to borrow skin from some other area of the body and put it back, replace it to the face. Or if a bone is gone, in the face, bone also gives a very definite structure to the face. So if bone is gone, we're able to take out a bone from the leg, which is the commonest used, the fibula in the leg. So that can be refashioned into either a jawbone or a maxilla, and it can be replaced. And that way, you're putting back even the aesthetic part of the face back to the individual. And there are 2-3 advantages if you look at it. One is basically, apart from curing the cancer, patient also needs, to have a very presentable face at the end of the day. You can't carry around a mutilating face and then be presentable. So we, as plastic surgeons, we try to put his form back. Like I said, the form and the function. Again, the same two goals are, kept in mind here. The form part, we are taking care of it. And at the end of the day, patient has got cured of the cancer. Plus also, you restore his confidence, and he can lead his life with dignity. That is the ultimate aim. And function wise, yes, with all the reconstructive parts, we try to replace, for example, when you do a surgery on the oral cavity, 2 most important functions can get compromised. One is swallowing. Whatever food he takes, there is a mechanism to swallow it properly. Otherwise, it can, patient can aspirate into the lungs. So with all these reconstructive procedures and flap surgeries, we're able to give that swallowing, back as a normal thing. So in a day-to-day life, we can eat normally and then live a good life. And the second function which can get compromised is the speech. Either the lip surgery, when you remove the lip, his speech will get altered. Even the palatal surgeries, the speech can get altered. Pharyngeal surgeries, the speech get altered. So that also is replaced with the use of flaps. So these few things, restore patients back onto their, the normal, leading the normal way of life.
Dr. Sunil Kumar, what is the role of plastic surgery in the lower extremity? What all can be done in a lower limb reconstruction?
Lower limb is an organ which bears your weight. So any problem with the lower limb, you will have problem with walking, running, or whatever day-to-day activities also. So there are initially, whenever you get a lower limb injury into a hospital, basically first it has to be examined by a plastic surgeon. See, there are a lot of components in lower limb, muscles, bone, arteries, and skin now. So plastic surgeon is a better person to assess what is the defect, what is the injury, and what tissue has to be replaced and when it has to be replaced. So initially, when we inspect the wound, the other surgeons like orthopedicians are also involved for the fixation of the bone. The skeletal stabilization is important for integrity of the lower limb. Once that is done and once the vascularity of the limb is good, then the reconstruction work starts. So usually what we do whenever we get traumas, first foremost thing what we do is good debridement of the limb. So once we debride, then we will get a time, we get a chance to think what is to be replaced and when it has to be replaced. And we wait for 24 to 48 hours for the wounds to settle down. Then we usually start with reconstruction. See the muscles, especially from hip to knee, usually the lot of muscles are there. Somehow we can cover the bone with the muscles and cover it. The challenging will be more when it is from the knee to the foot, that is the heel and the forefoot. See, usually the upper 1/3 of the foot can be reconstructed by the local flaps where we take the muscles and wrap around and reconstruct the defects which are there in the knee and the upper 1/3 of the leg. Coming to the middle 1/3 of the leg, there are some more muscles which we can wrap it and cover the bone and put a skin graft. Coming to the lower 1/3, usually when there is lack of local flaps, we need to opt for microvascular flaps. There are a couple of arteries which can be used. From the different parts of the body, we take muscles along with the blood supply and the skin paddle and cover the bony defects and give a good cover so that the fractured bone and the wound heals. And coming to the heel part, heel is one difficult organ. As I always remember, my guru, Dr. Anantheswar used to say, very difficult to reconstruct is the heel. See, whatever we cover the heel, the calcaneum bone, but that cushioning, that grip which we get from the normal heel pad is lost. But still we manage to cover that so that they can put a good footwear and walk around. So plastic surgeon's role is very, very important, especially in the lower limb, to assess the defect, to assess the wound, and when and how it has to be reconstructed.
I think, like what Dr. Bharath had initially said, that, it's not just the surgery, it's the form and the function, two things that you need to take care of as a plastic surgeon. Dr. Srikanth, now one of the challenges that women face after they go through a breast cancer surgery is the removal of the breast, and which usually is one of the concerns because of which they delay the treatment in the first place itself. Now, can you tell us a little bit more about the breast reconstruction and what are the things that a woman needs to take care of and keep in mind about the surgery and post the surgery?
See, breast cancer typically is a very personal thing for a female, right? Because it is a private part. Nowadays, awareness is increasing, with lots and lots of information available. Breast cancer, we are able to detect it early. But in the ones whom there is advanced disease or in a rapidly spreading disease, they're going for what is called as a breast amputation. That is a total mastectomy. The entire breast is removed. This cures the cancer, but it is very, very devastating for the patient psychologically. The thought of cancer, anybody, you, me, anybody, if you say you have got cancer, first of all, you're psychologically done, you undergo a breast amputation, you live with it, and it's a reminder daily that you have had some major event, some catastrophic event. So breast reconstruction becomes important because it restores the female back to her normalcy. We have very many options to do it, depending on the kind of patient, the kind of surgery that was done previously, kind of radiotherapy, what the patient plans in future. Like, for example, if they're planning to have a child, planning a family, or no, they have completed their family, we can offer many, many options for breast reconstruction. The most common thing we do is today in our setup is to do a breast cancer reconstruction on the day of the cancer resection. That is the primary reconstruction. These patients don't always require further surgery in the future. They are comfortable, they are happy, they undergo their cancer therapy, and they're off our radar. There is a subset of people who don't have access to primary reconstruction. We do a secondary reconstruction, that is a reconstruction at a later date, 6 months, 1 year, 2 years after cancer is treated. We can reconstruct the breast using their own tissues, that is using some breast implant and covering it with muscle from the back and abdomen, lower abdomen fat, skin, put it there, buttock fat, hip fat. So many options are there. We have a plethora of options for breast reconstruction, and these are times where, options are there. Patient has just to reach and ask for help. One thing I want to mention about in post-cancer breast reconstruction today is technology. We have breast implants. Everybody knows about breast implants. We can use it. We have heard of it. It has got its own fan following. Along with breast implants, we have something called as ADM, that is acellular dermal matrix. ADM is something that replaces flaps. So you cover the breast implant with the ADM and then pull the breast tissue, have extensive surgery like a flap surgery. And these technological advances, which were previously not available, or somebody had to go abroad, you had to fly to the US or Singapore or UK to get this done, we are able to offer it today. So breast reconstruction today is, I would say, the norm. In fact, every female who is undergoing a partial or a total breast amputation, we should offer them this option. Some of them are psychologically strong enough, they're mentally strong. They say, okay, fine, I'm not interested in a breast. I just want cancer treatment. I'll get on with my life. Yes, we are happy for them. They should do it. But there are a lot of people who, their life takes a complete U-turn when you say that I've had a breast amputation, especially the younger ones. So we tell them, yes, we have an option for you today. We can do a breast reconstruction. You'll be happy. And in fact, if you choose a lower abdomen reconstruction, you get a free tummy tucker with it. So you look even more better. So, we have a lot of options today with breast reconstruction. And there are innumerable studies across the globe which say that patients who have had breast reconstruction have had much better quality of life as compared to somebody who has not had a breast reconstruction. And the questionnaire also goes to say that given an option, those people will say, yes, we would have liked to take a breast reconstruction. So this is the message I'd like to tell everybody. We have options. If it is troubling you, come to us. We can treat you.
Brilliant. Dr. Anantheswar, my next question to you is about what is the incidence of the problem of the cleft lip and the palate? And how do we treat it, and what are the kind of timelines involved in treatment of these health conditions?
So in about 650 to 750 births, one of the child will get affected by either a cleft lip or a palate, or both actually, cleft lip and palate. So it is a common sort of a myth amongst the public that look here, when she was pregnant, she has witnessed a stellar event like either a lunar eclipse or a solar eclipse. So that is why she is born with a child like this. Actually, it is all quite meaningless. It's got nothing to do with that thing. I usually tell them and compare it to a mango tree which keeps on giving thousands of sweet fruits. Once in a while, one of the fruit becomes a little bit sour. Doesn't mean that you blame the tree. It is like that. So in effect, the treatment of a cleft lip and palate is one of the most enhancing experience for a plastic surgeon. Usually here, if you see the children born with a cleft lip and a palate, they have an extra sparkle in their eyes compared to the normal children. So we always say that, don't waste any time in transgrading that sparkle from the eyes to the lips. That means don't waste any time in doing the cleft lip repair. So we have usually as a protocol-based timeline schedule for most of these children and the parents. First is the good reassurance to the parents, especially they will be more devastated to have a child like that, and they will be socially, sort of going into some sort of an incommunicado. Means they don't like to meet up with the things till the time at least some sort of a surgery is done to bring back the child to normal. So the first surgery, we usually do it around the age of 3 months, where we do the cleft lip and the front portion of the palate or the inside of the palate portion, we repair it at first. And the child goes on with the normal feeding habits so that, the child also grows up a little bit. And by about 9 months to 1 year, we plan to do the palate repair. So the palate is the inside the mouth where the palate is also bifid. So that needs to be brought back together. An essential reason why we have to do it is if you don't do that, they will have a speech problem. If you do that in the right time, because normally I expect that it's around 9 months of age, the brain starts developing the centers. It's like a child's brain is like an empty CD. So it starts taking one note for each dot and then start registering it to the brain. And so if you can restore the anatomical integrity around that age group, so you will get the best of the speech. And one more thing which I add on to it is that, our Sanskrit language and all the other languages of our country, India, they have 52 alphabets and they're all essentially derivatives of Sanskrit. Whereas if you see an English language, it's got only 26 alphabets. So we have virtually our children, these cleft lip and palate children whom we have operated at the right time and the right age group. So they suffer virtually from no speech defects at all, except for speaking where they have a little bit of nasal intonation. Apart from that, there is no difference in their spelling, pronunciation, and other aspects of this. Whereas the speech therapy is the big issue there in Western countries. So because they have a huge departments which are running around for the development of that speech. So fortunately, because Sanskrit is such a nicely mathematical language, so it virtually comes up to sums up in giving a very good language. Second thing is when the child is going around 5 years, just before the school age group, we try to reconstruct the little bit ale of the nose, or what we call it, the tip of the nose, where the cartilage will be a little clump will be there. And the next stage will be when the child is around 8 years, when the milk teeth fall off and then the permanent teeth come. That is the time we may like to put a small sort of a bone graft into the gap so that the permanent teeth can come into the rightful position. And the next stage is around, let us say, 11 years, because the teeth can be in a little bit of crooked fashion. So we usually call a team called as the orthodontic treatment, in which we align the teeth with application of braces, and by about 14 to 16 years, the teeth is virtually aligned into the normal position and the shape. Now, with all these things, there are some amount of structural integrities which can be disturbed by the child achieves the age of around 18 years. So when the bone growth is complete, if you see some of these children, the cleft lip and the nose, it is also called as the cleft lip nose deformities, in which the nose can be a little bit of deviated to the right side, and the scar can be a little bit more, visible. And of course, the central portion of the maxilla, or what we call the midface, can be a little bit retruded, can be behind in position. So all these things can be addressed by a procedure called as a composite correction, which I usually do it at the age of around 18 years. So earlier, what they used to do was cleft lip and say, okay, fine, you do it at 3 months of age. Some of them even go to the camps and then get it done where the public awareness is not there. So resulting in a lot of suboptimal results. Now, it is a journey which I always tell that, the parents have to undertake with the operating surgeon, not just at 3 months of age. It is up to 18 years of age, till we feel that the child has become a normal adult without any inferiority complex. That is where a successful outcome of the patient as well as a successful outcome for the operating surgeon. It's a very gratifying journey. It's a very gratifying result for the patient. And I feel that a lot of social responsibility as a treating plastic surgeon is there for the cleft program. These are my words.
Awesome. Awesome, Dr. Anantheswar. Dr. Bharath, we've covered a lot of different subjects. I did not know first that the plastic surgery had so many things involved in this. What I would like to understand from you is what is brachial plexus? Am I pronouncing it correct?
Yeah, yes.
Awesome.
It's the brachial
plexus. And what are the problems that are usually associated with this surgery or the treatment process?
Yeah, I think the nerve surgeries, the awareness about nerve surgeries is one other thing where we need to, as plastic surgeons, kind of work towards the awareness. And many patients don't even realize that we operate on nerves. And to be more specific, we deal with all the nerves which are peripheral. Basically, we keep away the brain and the spinal cord, which are dealt with by the neurosurgeons. And this brain spinal cord is the ones which gives out the peripheral nerves. All the relay comes out and then it goes to the limbs and the lower limbs, upper limbs, everywhere else. And they are the ones which carry the functional part of the message, also the sensations and things like that. So whatever is related to, for example, any peripheral nerve injury or anything, we tend to operate on that. And brachial plexus is one particular set of nerves. It's about a set of 5 nerves, which actually comes out from the neck and comes into the neck and enters the upper limbs, both upper limbs. And they are very important in the sense that, it supplies the entire upper limb, right from the shoulder function to the elbow function to the wrist function and even the fingers. So entire the flexion, the extension, there are different joints here, there are different muscles, many set of muscles. Everything is taken care and supplied by the brachial plexus nerves. So any kind of injury to this brachial plexus is what is broadly called as the brachial plexus injuries. And in terms of awareness, what we always struggle as plastic surgeons is many patients being not aware that whom to approach for these problems, they tend to present very late. And especially in a nerve injury or a brachial plexus injury, presenting on the right time is very, very important, because there are multitude of options to be offered to the patient, and then they can get better, a lot better in terms of the function. And this is one subset of plastic surgery where the focus is entirely on the function, because the upper limb, obviously without the upper limb, the person can't lead his normal life. With a palsied upper limb, he can't lead his normal. So that way we, the timelines are very, very important with these brachial plexus injuries, preferably on day 0, like Dr. Sunil Kumar said, it's better to involve a plastic surgeon if they suspect a brachial plexus injury, and then fix up the timelines depending on what injuries are there. So roughly it is about 3 to 6 weeks time when we know that are there going to be any residual palsies at all in the upper limb which is injured by brachial plexus. If it is just a very blunt injury to the nerves which has happened, that itself can cause a palsy. But just a blunt injury will recover itself in about 3 to 6 weeks time. Nothing needs to be done. So that is the time of roughly about 2 months time you wait for any recoveries to happen in the palsy. Whereas beyond 2 months, if the recoveries don't happen, that is when we investigate. We can do an MRI of the neck. We can do nerve conduction studies to see what is functioning, what is not functioning. And accordingly, we do the surgeries. Surgeries also, there is a varied type of surgeries. Earliest they come, we can explore the neck where we suspect an injury. And if those nerves if there is a physically, it is cut, then those can be joined and then allow it to recover entirely, and then allow the function also to recover. So that is something like a best bet for the patient. Whereas if he comes, say, roughly about 4-6 months later, then the primary nerve repair surgeries are not an option at all. Because what happens is during this interim of 6 months, the muscles have not received any kind of signals from the nerves. So they kind of atrophy. It's called a disused atrophy. They're not used and therefore they atrophy. So even if you join the nerves taking the signals to the muscles will not elicit the muscle response. The muscles are, practically dead, you can call it. So that will not help. So then we'll have to look at some kind of, other tendons which are there. Normally functioning muscles or a tendon has to be transferred to a functional surgery. So those are called as tendon surgeries. And sometimes while joining the nerves, there can be a huge defect in there can be a loss of the nerve itself when we take spare nerves from the leg, the commonest being from the leg. So we use it as conduits, as a graft to join these defects. And in spite of all this, some patients come at 1 year, 2 years when all these tendon surgeries, nerve surgeries may not be possible at all. So that is when we think, and especially in patients where complete all 5 nerves in the brachial plexus are damaged, we don't have any other usable nerves in the hands. That is when we even go to the extent of taking a muscle from your thigh along with its nerve supply and then replace it to the hand and then connect it to a suitable functioning nerve somewhere in the neck or in your chest, so that nerve grows back and this thigh muscle functions and then helps bending the elbow or the fingers. That's called as functional muscle transfer. So there is a huge gamut of the surgeries for the brachial plexus injuries and nerve injuries. But the biggest challenge, like I said, is only the timing. The patients have to come, be aware of it, and then come on time. And the other biggest challenge is all these nerve recovery. At the moment you join the nerve, it's not that the next day it is going to start functioning. No, The problem with the nerves is wherever it is cut, the moment you join, from there on, new nerve has to grow into the tube and then reach the muscle. So that is going to take a lot of time. We literally say that, every month the nerve grows by about an inch forward. So you need so much of time to be given, say about 6 months, 9 months, and a year or so, for the recovery to be seen. So that is when some patients, they lose their motivation. They're not seeing the desired result immediately. And that is when we also tend to lose the patients for a proper follow-up. So these are some of the challenges, to educate them and then keep them on track. And after all these surgeries, they need a proper physiotherapy for all the muscles to be kept stimulated, and then all the joints to be kept supple. So it's a huge plan, which both the surgeon and the patient has to understand and then take it along. Roughly, say about a year or two, when they can see ultimately the result.
Got it. So I have one question, Dr. Sunil, before I, come to my final closing question. One thing that we have not covered until now is the deformity post burns. And how can these deformities be treated? And usually when it is on the face or these kind of areas, would it impact the regrowth of hair in these areas? And how do you treat the post-burn scars?
Yeah, to start with burns, see burns, there are degrees of burns. So anything, first degree burns is just superficial burns, which heals on its own. It may take around 1 week to 10 days, but it heals on its own. Regular dressings are sufficient. Coming to second degree, it is along with the superficial layer, the second layer is also involved, and it requires almost 2 weeks to settle down. There are newer dressings called as collagen dressings and all. We clean it up and put collagen dressing and it will heal. And coming to third degree burns and all, it's a full thickness burns where the skin completely gets burnt. It has to be replaced. Most of the time, post-burn contractures happen in low socioeconomic status people because they are the ones who use kerosene and they use stoves, and the burns happen and they don't have proper financial status to treat. So they end up developing contractures because of improper and inadequate and treatment not given at the right time. So coming to post-burn contractures, whenever there is full thickness burns, if the wound is not covered by the skin, then it starts contracting. So it starts contracting and it goes to forming a deformity where you can't do your regular activities. So what we do is we try to assess the defect. Suppose if you have a defect in your hand or in your neck, with the other contralateral area, there's something called as a true defect and apparent defect. So if both the sides are involved, the same stature person is taken and measurements are taken, and we reconstruct either with the grafts or with the skin flaps. So whenever there is vital structures involved underneath, where after excising the post-burn contracture, if you have vital structures like blood vessels or tendons or bone exposed, we have to cover it with a muzzle or a flap cover. And suppose if you have adequate soft tissue underneath, we just have to release it. It's something called as incision release or excisional release. So we incise and release the contracture and graft it, or we excise the post-burn contracture and then graft it, provided there is a good bed to take, graft to take. And coming to the hair-bearing areas, see, if there is full thickness burns, then there won't be any hair bearing in that because the hair follicle, the root, everything gets burnt. So that either you can transplant the hair in that scar areas, or suppose if it is in the scalp, we can do some flaps and rotate it and cover it and make sure we get a hair-bearing areas.
So great. I mean, this has been a really interesting conversation because not only did we understand the various aspects of plastic surgery and the different treatment options available for different conditions, but we also try to break away some myths. I'm pretty sure there are many more that can be spoken of. But my parting question to all of you is that, I heard Dr. Srikanth, you had mentioned in one of your answers saying that, I think it was for breast reconstruction, that you said in old, few years ago, people would go to Singapore and get surgeries done. Do you think we are now, both in terms of talent as well as in terms of, technology, at par with the world? And what are the areas that you feel that we still need to achieve much more and become better?
Well, to answer that, yes, I think we are on par with the best in the world. As far as the skill goes, as far as the talent goes, as far as the surgical part goes. Technology, we are getting there. It is expensive. Getting the latest technology to India is expensive, and you must, as you all know, healthcare in India, 80% is borne by the patient themselves. So the minute you say expense, that means the burden falls on the patient. There is no way we have a state-sponsored healthcare system where they can have access to latest technology. So that, I think, is the biggest problem. As far as the skill set goes, as far as the kind of procedure that go, because of easy availability of information, easy availability to go train ourselves abroad, we are as good as the best in the world. Technology, we are getting there. There is some amount of lag between something that gets released in the US or Japan, and for that to reach here, it takes a time lag of 6 months to a year before we have access to such technology. So we lag a little bit in that, but I think we're getting there. Hopefully things will be better and faster. The challenge is making it affordable. Technology today is expensive, whether we like it or not. That's the way it is. The only way we can reduce the cost is to make it more widely available, and the price comes down. When it is more widely available and the numbers increase, the companies automatically bring the price down so that it is because it covers their costs. But as long as it is expensive, it is it is available only to a select few who can afford it. I think that is our major challenge as far as technology goes. But skill-wise, I think we are right there at the top.
My question is, I want to ask one more question before I let you guys go, because it stems from what you said, and it is extremely, extremely important. I feel that, here we are talking of a specialty or a specialization which caters not only to a medical requirement of a surgery, but it is also catering to, say, cosmetic part. It helps you look good.
Yes.
Is there a way, and we have come a long way in terms of affordability and accessibility when it comes to the world standards. So you don't have to go one because the technology is not available or the skill is not available. It is also cheaper than the rest part of the world.
Correct.
But it is still unaffordable for a large part of our population. Is there a way to separate the medical part and the cosmetic part and make the medical requirement for a surgery more affordable? Any thoughts that anyone wants to share on this group? Any suggestions?
Already, see, some of the things are like this. The procurement of the skill or procurement of the technological advances is one aspect of it. Putting it to execution and then to ensure that it reaches the common people or the end users, I think that is where probably the system, that is where the government has to come into the picture. To some extent, I will say that unlike Western countries, we have a heady mix of, let us say, about 50% is sponsored by the patients themselves. Let us say another 30 to 40% is sponsored by the insurance companies, and another 10% is sponsored by some philanthropic organization. This is the general classification which I'm just telling you in which a patient undergoes. Now, if you're asking on par with about the technological advances or for that our knowledge-wise or our skill-wise, I think if we can see the number of patients we are getting from abroad for treatment with us, that will show volumes about our skill and our capabilities. The medical tourism itself has overshot like crazy. In the sense, if you see any of these corporate hospitals, many of the major places, we have been doing on many of these patients who come from there, because firstly, they cut their waiting list, and at the cost which they can't even think of getting these surgeries done at that rate in their countries. So that aspect is over. The second thing is, in which how we can put it across is probably the government has to make in some sort of a issue in which we can separate the cosmetic surgeries, which are anyway are not so covered under insurances. So their patient knows that he has to pay, or he has to make sure that he has to be available. The other way is to ensure that all the government hospitals, when they come into it, actually the teaching hospitals where they are there, so they are the ones which need to be sort of health budgeted upwards. Unfortunately, our health budget is less than probably 1.5%, which is a really minuscule. I think that should be the way about it, actually. 1.5 to at least 5% more. So probably I think it will go a long way around it. Yeah. This is my thought about it.
See, to add to what Dr. Anantheswar said to his last statement, if we have to make it available to the public, it should be there in the public hospital.
Yeah.
So what the government should do is to make sure that every single government hospital has a plastic surgery department. That itself will cater to a huge number of people. I feel that, if the government makes it compulsory that every teaching hospital has a department of plastic surgery, that itself is a step enough to reach to the masses. Make it compulsory that you have to have a plastic surgery department, provide adequate staffing, provide adequate funding for that department, as you're doing it for other departments like general medicine, surgery, obstetric and gynecology. If it is made compulsory that you will have a plastic surgery department, I think from there on, it will be a natural growth for the specialty, and, we'll be able to reach out to much, many more people. As far as separation in cosmetic and reconstructive surgery goes, I think it is left to the individual surgeon. Some people practice exclusively cosmetic surgery and they are very good at it. They are top class, world class. Some people practice absolutely purely reconstructive surgery and their entire careers go in reconstructive surgery. So that part I think is automatically taken care of as a personal interest point of view. But if the government ensures that, yes, all our teaching hospitals will have a plastic surgery department and that give access to the patient to go to a plastic surgery department, that itself will be a huge thing as far as plastic surgery goes.
With that, we come to an end. I think it has been a brilliant session, brilliant suggestions on how to make it affordable, accessible. We have come a long way. We have the best talent available. We have all technology available to us to make us proudly at par with the world, if not better. With that, I want to thank each one of you for taking out time. Spending an hour and a half on a working day means a lot. I personally thank Dr. Srikanth, Dr. Anantheswar, Dr. Sunil Kumar, and Dr. Bharath. Thank you so much for taking out time to be with us for the World Plastic Surgery Day. Thank you so much.
Thank you very much.
Thank you.